All right, well, hi everybody, this is Dana. I think we're about ready to get started. It's noon, so we're going to go ahead and get the ball rolling for our web discussion today. We are delighted that you've joined us today for our part 2 of our web discussion about using a primary service provider approach to EI service delivery. This web discussion really has come about because you've asked for it. Our last web discussion last month in February was part 1, and that's really all we had originally planned was part 1. But we had so many good questions, such a great chat with our web discussion last time, and some good follow-up questions since the webinar. We decided we wanted to take more time on this topic because we know it's important and folks are interested in it. And we really wanted to offer Susan and Tracy, our presenters from last month, the opportunity to talk more about their experiences with using the primary service provider approach to early intervention. So we're pretty much just going to dive right in. Today's presenters, you know, it's funny, I should have taken myself down. I'm Dana Childress. I'm an EI professional development consultant with the Partnership for People with Disabilities, and I'm actually not going to be presenting so much today as hosting. So I will be kind of keeping us moving today and keeping up with your chat. And fortunately today you're going to get to hear a lot more from Susan and Tracy about their experiences. So Susan, you want to introduce yourself?
Sure, thanks Dana. My name is Susan Sigler. I'm the clinical coordinator at ITC in Fairfax Falls Church. I'm also a speech pathologist by training, so I'll try to get some of that in today. We've got Tracy here who's a physical therapist, so we will address some of those clinical questions that came up, and I'm really excited to have this opportunity to reach out to more people and answer some of the questions that we got during and after the chat last month. So I hope we can get those answered and be available to give more information if needed.
Great, thank you, Susan. Tracy, you want to introduce yourself?
Yes, my name is Tracy Shiplett, and I'm a practicing physical therapist as well as a clinical director at Therapy for Kids. We're an agency that contracts with Fairfax County, so I'm here today to really support kind of how, as a contractor, we've made it work with local jurisdictions and kind of some of the struggles as well as successes we've seen with the primary service provider model.
All right, thank you, Tracy. So yeah, so it's exciting today because we could just present a webinar about the primary service provider approach, but I think what's going to be a lot more effective is you guys are going to get the opportunity to ask questions of folks that are doing it and doing it well. So let's jump right in. So our agenda for today is we're going to talk a little bit, Susan's going to kind of get us reoriented, and we're going to talk about why it's important to use and to consider using a primary service provider approach and how that benefits children and families. We're going to try to answer questions raised in the part 1 web discussion. So if you missed that web discussion, I encourage you to go back and watch it. It's available as an archived webinar on the Virginia Early Intervention Professional Development Center website. But you're also going to be fine just jumping in today. If you didn't join that webinar, we're going to have the questions posted on screen so you'll be easily able to follow along. And through answering those questions and even kind of beyond, we're going to hear from Susan and Tracy who are going to tell us about their experience implementing the primary service provider approach to teaming. So they're going to share with you lots of tips and strategies for system managers and providers, service coordinators, folks who are considering implementing this approach in their system. So before we get started, we wanted to find out where you are located. We were surprised to find that our last web discussion had quite a big showing of folks actually outside of Virginia. So we wanted to get a sense of where you were today. We only had 5 options that we could offer for our poll, so that's how we're going to find out where you're located today. So we've kind of divided Virginia up into northern, central, southwest, and coastal Virginia. Not probably the most ideal way to do it, but I'm hoping you can find your place in one of those. If you're outside of Virginia, you'll click option E. So let me tell you how to do that. You're going to move to look to the left of your slide, and you'll see a vertical toolbar it's kind of outside of the participant box. The second little square down on that vertical toolbar should look like maybe a smiley face or a sunburst or a little check mark. You're going to click on that little icon. It's your little pointer icon. You might have an arm extend that shows you other pointer icons you can use. We'll click on one of those. Once you pick one up, you can I'm taking you through the pointer instead of the poll. That's fine, let's just do it as a pointer. So go ahead and lay your pointer down on option A, B, C, D, or E to tell us where you are. I guess I'm really excited about using the pointer tool today. If you're outside of Virginia, sure, you can put yourself on the map. That's awesome. Yeah, that's exactly what I was thinking. We'll go with that. All right, so I'm going to give folks a little more time. I see, oh good, Jamie's got the poll up and running too. So some folks followed the directions that I missed giving them. So we'll have the pointers and the polls. This is awesome. We're flexible, right? We're early interventionists. All right, Jamie, would you go ahead and publish the poll on the screen? And we'll just compare and see what we've come up with. All right, so we've got a mix, kind of like the mix we see on screen. So we've got some folks from all over the place. One person pointed to Virginia. Awesome. So we have folks from northern and central Virginia. We have coastals, which is my area too. Looks like most of our folks are probably, I don't know, it's kind of a little all over the place. And then a couple people from outside of the state. So it looks like somebody in California, and if I knew my geography better, I would know there's somebody up sort of in the northeastern part of the country. You can type that in. I'm so bad with, I'm embarrassing myself. I'm so bad with geography. Alrighty, so this is nice to see. We've got lots of folks in Virginia and some folks outside. So wherever you are, feel free to ask your questions today, and we will do our best to answer them. So thank you guys for playing along with that. Okay, so next where we're going to go next is Susan's going to kind of take it over from here and walk us through kind of some of the reasons why considering this approach can really benefit children and families and benefited providers, those of you that are thinking about working within this approach. So Susan, go ahead and take it away.
Okay, thanks Dana. It's interesting to see where everyone's from, and hopefully we can address your questions based on some of the things you might have specific to your locality. But after the last webinar, I really wanted to take a step back and make sure that based on some of the questions we got, I thought we wanted to make sure we ground ourselves in choosing to use the primary service provider approach for the reasons that it's going to be most beneficial for children and families. So there are some other consequences of choosing this approach, but we want to really make sure that before we take a step forward of even trying to move down this road, that we are using the right, or making the decision based on the right information. So why do we want to use a primary service provider approach? Why was it included in the 7 key principles? We know that in those 7 key principles we talked about in the last webinar, they actually even talked about using a primary service provider. We want to really focus on the fact that this allows a relationship to be developed with the provider and the family in order to promote a conducive learning environment for everyone. So the idea behind this is that you really want to be focusing on that relationship building with the family and the primary caregivers. We want to enable families to establish and maintain an ongoing working relationship with a lead team member that also has the needed expertise. So we really want to make sure that we're giving families that opportunity. We want that lead team member to be able to focus on the whole child and family rather than just promoting an isolated focus on one developmental domain or like a very specific developmental deficit. And we're going to talk about that a little more as we address some of the questions, because some of the questions we got were, but what if the child has this? And we're going to talk about that. You would have the right person in there to address that, but they'd also be looking at the whole family and the whole child. It also minimizes the potential negative consequences of having multiple providers who don't communicate or frequent changing of providers in a child and family's life. We know in early intervention, at the most, we have children for 36 months, and that's a really short period of time in the span of a child and family's life. So we want to try to make that the most beneficial time for families. And one of the things we know is that if they have a good relationship with somebody, they can learn more during that time. We also want to minimize confusion and conflict and fragmentation, and that has to do with when we talk about teaming and documentation, how that part of this approach really does help that with families. And we also want to really make sure that using natural learning environment practices and a family-centered approach, that this way of providing services allows us to focus on building the strengths and the capacities of families. But the bonus to that is it also allows us to focus on building the strengths and capacities of our colleagues and our peers as we work together with families. Okay. So I think we have to sort of make sure we discuss what the primary provider approach is not. And as I looked at, we did talk about this last month, but as I looked at some of the questions, I thought, gosh, maybe we as a profession and as we approach children, that we might be perpetuating some of the myths that are making our referral sources confused, that are making our families confused. So we want to make sure that we know what the primary provider approach is not, so that we can be really clear about what it is as we move forward. So there's a few up here on the screen I'm just going to reiterate for you, and then a couple more to talk about. First of all, it does not mean working as a lone wolf or all by yourself. It does not mean you have to know everything. I think one of the things I want to make sure people walk away from is that every family and provider should know that if you're working in this approach, you have a strong, supported team, supported and supportive. It does not mean each child can only have one provider. So those of you might remember some of the questions we got last time were things about people feeling uncomfortable because they were the only person in there. I know Tracy and I have been talking as we prepare for this, and the main thing we want to stress is that individualized is still the key word in our IFSP development, that because you adopt this approach doesn't mean that you have to have one provider in there. So please, if you walk away with anything, make sure you walk away with that. It does not mean that there are lower frequencies for services. You may actually have a higher frequency at some point. It just means that there are fewer providers in many instances, different people, but you might have one person who's going in twice a week for a period of time. It does not necessarily cost less money, and a lot of you had questions around that. How do you pay for teaming? How do people get reimbursed for that? And we're going to talk about that from a practical standpoint, from a provider standpoint, Tracy will share, and also from a contract standpoint. But please know that it does not mean that it's going to cost less money to provide the services as a whole as a system. And it does not mean that the same staff are always the primary provider. So it would not be using the primary provider approach if in your system every child got education. Okay, so I'm just using that as an example of some of the questions we got. That would not be using the primary provider approach. So hopefully that helps you. I think when I saw some of those comments, the reason I really wanted to focus on this before we got talking about the specifics is that I worry that as we put anything into practice, whether it's in Virginia or outside of Virginia, that some of those myths we talked about last time are things that we are perpetuating by the way we implement the practice. So if we're not implementing it appropriately, sometimes we're hurting ourselves with our referral sources and our families. So they might get the idea that, well, I just have this one person and I don't know anything about the team that supports me. So we're going to focus today on how do we make sure that everybody knows all of the components of the approach. Okay. So let's then, now we talked about what it's not, let's talk about, just as a quick review, what it is. What are the key characteristics when you're using a primary service provider approach? First of all, it's one staff member must be primary even if multiple providers are on the IFSP, so that people as a team know who is primary, who is really working on looking at that child as a whole and building that relationship with the family. It should have joint visits that occur to support the primary provider. So when there are secondary providers, those you will often see those as joint visits where they're going in so that that primary person has a good grasp on what the other professionals are sharing with family. The teams should be clearly defined. So you want to make sure that you know who the team is for that family. They're not all on the IFSP. I know that was one of the questions that came up before, but if I was a speech therapist, I would know that Tracy was my go-to PT if I had questions. Every provider must be available to serve as primary. So it can't be a system set up where only one type of provider can be primary. You need to be able to choose the correct primary provider based on the needs of the family. And we'll talk about what we consider when we make those choices. Each team, we talked about that clearly defined team, each team must have at least one provider from each discipline. So we talk about our key. In Virginia, we consider the 4 primary disciplines: developmental services, occupational therapy, physical therapy, and speech therapy. You might have some specialty disciplines that cross teams, and that is how we do it here in Fairfax, where we have nutritionists, vision specialists, social workers that function on multiple teams. But each team knows they have access to those professionals. You need to make sure that using this approach incorporates a strong emphasis on building the capacity of the providers, building the capacity of your colleagues. You do want the primary service provider to change as infrequently as possible, but that doesn't mean it never changes. And that all team members must attend formal meetings so that we know that there is time for these people to be supported in providing those services. So that's an overview of the key characteristics.
Okay, so now we wanted to find out how comfortable you are in the role of a primary service provider. So when you think about what Susan just described, you can think about this from the perspective as somebody who's already doing this and who's already acting as a primary service provider, or if you're somebody who hasn't really done this before. When you think about it, how comfortable do you think you would be in this role? So we're going to try out the pointer tool again, since you guys are so good at it from our last activity, and I see people are already starting out. You're going to look to the left of your slide. That vertical toolbar is there. The second box down, you'll find your pointer tool. So you click on that second box down, click on the icon that you like, and then drop it in the box on the image that you think best matches you. Very comfortable, average comfort level, or you're not really comfortable at all. I'm pretty impressed. Somebody has dropped a smiley face, a yellow one, and I don't even know how you did that. That doesn't look like one of our pointers, so that's pretty awesome. So it looks like as folks are putting their pointers in the boxes, we have a mix of very comfortable and about an average comfort level. So I think that's pretty great. It looks to me like it's about equally distributed. Looks like we don't have anybody who's feeling not comfortable at all with this role, which is a great thing. And I think, Brandy says I used a picture tool instead of the pointer tool. Brandy, you've taught me something new. I didn't even know we could do that today, so I'm going to have to check that out afterwards. But I think it's interesting that we don't have anybody falling in the not comfortable range, because I think being a primary service provider isn't really that different from doing just good early intervention practice, because we have to know about development kind of across domains, but it's sort of how the team works that's where the difference happens. What would you say, Susan and Tracy?
Yeah, I think this gives us some great information, and lets Tracy and I sort of head the right way as we give these answers, because I'm guessing that people are feeling comfortable, but their questions are then around how do we make it happen?
Exactly. That's what I'm thinking too. So thank you guys for giving us a sense of how you're feeling. Let's go ahead and jump into our questions and hearing more about how things work in Fairfax Falls Church. So again, I'm going to turn it over to Susan, and they're going to give us kind of an overview of how things are working there, and then we'll walk through some questions. Now some of the questions I'll ask Susan and Tracy to kind of give us their perspective first. Some of them I'll throw at you guys in the audience to get your perspective. So if you have additional questions that pop up as we're talking today, feel free to put them in the chat. So go ahead, Susan and Tracy, tell us a little bit about how things work where you are.
Okay. First of all, I want to say it is a work in progress. We are happy to be sharing this information with you, but we certainly, neither Tracy nor myself would say we are doing it perfectly, that we are textbook perfect at doing this. What I will say is that we have recognized it's something we want to move towards, and that we've put the supports in place to move that way. So that's what we'll focus on, and what we hope we can share with you as providers and local system managers of just some of the simple things you can do to get on the track if this is the track you want to be on. One of the first things we did was put together a 90-minute training for everybody. Just a basic PowerPoint presentation that we did to get people going and ready for the implementation. And along with that, we did some activities just to measure and also to allow some practicality of that. I do want to say that we did set up our contract with vendors to require a team of all 4 disciplines and regularly scheduled team meetings. We are going to talk about what that team looks like, but I'm going to let Tracy just talk real briefly about just a basic backbone of what that looks like for her agency.
So our agency has a staff of about 24 individuals, and we do, of all disciplines, OT, PT, speech, and education, and we conduct meetings several times a month of different types of meetings to try to support this. Some of those being a whole staff meeting where we team kind of bigger issues, things that are applicable to multiple kids. And then we do smaller group teamings with the same crossing of OT, PT, speech, ed, and service coordinators from the county present to try to help support those more fine-tuning, individualized cases and issues. And this is what helps us guide a lot on what is needed for a family. Is it a mentor? Is it a additional visit that gets added to the plan? Is it someone that just needs to come out and look, or is it just suggestions that a provider needs?
We also put into place the clinical support that we needed as an agency. So we do require in our contracts that they have a clinical person who's sort of doing oversight and making sure that the staff is competent and supported in providing the services. And we also have my position and one other position that supports the clinical implementation of the IFSP. We want to make sure that people don't feel like a lone wolf, that they feel supported. Along with that, we did institute a system that allowed us to have oversight anytime an IFSP team added a second provider to their IFSP. Now, when I say oversight, it did not mean that we went in as an agency or as a local system and nixed it. It was not any sort of, they didn't have to get permission to have added that second person. What we do, and we still have this procedure in place, is what we're looking for to support the system as a whole is that we can go back and look behind the change to the IFSP. What was put into place? Was the team meeting regularly? Were they documenting? Did they look at all the IFSP outcomes as a whole when they were making decisions about the providers? And that system-wide oversight, we partner real closely with our vendor managers and clinical support people so that we're all helping to support it together. We did make some changes to the way services were written on the IFSP. Prior to the implementation of this, we specifically used a monthly frequency, 4 times a month, 2 times a month, once a month. We had moved into using an annual frequency to support the primary provider. We are in the process of changing that to a 6-month frequency because we know that at the very least the plan needs to be reviewed every 6 months. So for example, you might have a child whose primary provider is speech therapy and they are seen 4 times a month, and the secondary provider may be on the plan 4 times over the next 6 months. Again, we provided training to support how that visit is triggered and how we document that person's participation.
Let's get this right into the next question, I think, then. So if we think about how does the team determine that? It sounds like, I love it that you did a lot of preparation to get everybody on the same page, kind of set that up across your system that this is the way we were going to operate. And I think, like you said before, this is one of the things people really want to know. So what's it look like? How does the team actually determine who that person will be? And if it's okay, I'm going to throw this out to the folks that are listening. And I'm wondering, how's that working in your areas? Or how do you think the IFSP determines who the primary service provider will be? What does an IFSP team consider when they're trying to figure out who that primary liaison with the family will be? So go ahead and type into chat your ideas about how we would determine a primary service provider for a family. So I'm going to pause. I see some folks are starting to type. I'm going to see what our listeners have to say, Susan, and then I'm going to throw it back to you and Tracy to see how it's working for you guys.
Great.
So it looks like Brandy says, yeah, family priorities first, then goals. Absolutely, Brandy. Everything we do is outcome driven, so you hit it right on the head. Stacy says based on an individual service area, so if you have maybe your areas divided up by different groups of providers, that might play into it. Prince William again says family priorities and outcomes. Tracy said the same thing. Yeah, I think we've got a nice pattern here of looking at the family's priorities first. Then we talk about what's most important. Amy says we discuss the child's needs are. And if anyone already has a relationship with the family, that's an interesting point, Amy. We're going to talk about that a little later. Susan's going to talk about asking the team, who do you already think is the primary provider? And Corey says, I guess I'm wondering if it's a problem that someone becomes a default PSP. I don't know if you want to tackle that one, Susan, or I think you mentioned that before. I know we're going to talk a little bit more later about how teaming works, but that idea that we don't want to have default PSPs, that it's just always the same person across all children or always the same discipline, that's certainly something we wouldn't want to see. Teaming not aiming. Sorry, my keys got stuck. So yeah, I think we're seeing a nice pattern there. What would you say? How does it work in Fairfax?
Okay, I'm gonna talk about the practicality of the first IFSP, and then I'm gonna let Tracy talk about what that means when we have our reviews. Okay, so some of in the beginning, I will say a lot of it is based on the family's priorities on those outcomes. We're just sort of making a guess of what the best discipline is, and that has to do with the way our system is set up. And we know that that's not the best way to pick the PSP. For example, textbook perfect would be you knew every single provider and you picked the individual provider who was going to be able to do that. We have over 150 providers, so when we're writing that initial IFSP, we haven't picked the specific person. So we are looking at exactly what you guys wrote there in chat. We're looking at the parents' goals and priorities. We're writing the outcomes first, and then making a decision about what the primary provider will be. Certainly, there are times when as we go out and actually choose the individual, that we have to go with the schedule availability, the geography. Reimbursement comes into this sometimes. If a family is has one service that might be covered and not another, sometimes that's even considered. So many of those things are in the initial process. But I want Tracy to talk a little bit. One of the things we try to focus on is how it's still a flexible IFSP. So she gets these kids assigned to her, and what happens once they get assigned there? How do they decide who's primary, who stays primary? What does the teaming look like to help figure out who is the best PSP?
So I think we get a good sense, and we get the children referred to us directly after their ASP is done here. And our therapists are assigned based on the little information we get from what the IFSP says on the picture with outcomes. But I think it's really important to remember that IFSPs are flexible and can be changed. So that sometime an IFSP may start out with a speech therapist as the primary, but we find that that person isn't really the right fit, and maybe another person could change and be a better primary provider. So I think that's a really big key as we look at things, that these IFSP reviews can help find the right primary provider, whether it's the same discipline or a different discipline. The big key, though, we get the benefit of as these have ongoing reviews is that we have a relationship. We have something built with this family. So we go into these reviews with knowledge on what the family's concerns and priorities are. And we also have that background knowledge of knowing who's on our team who can best support us. So we really know that just because this child has feeding issues, that it could be this OT on our team, or it could be this speech therapist on our team, or the PT that's in there could have the skills to handle it. But we get the advantage of knowing that, and I think that's really a great point about having a team behind you the whole time as you go, is that you know who those people are, so you pick the right person based on who is the right match for this family and their needs.
That's a great explanation, Tracy, because sometimes what happens is we get feedback from our vendors. Let's say we had recommended speech because the child has some feeding concerns, and they come back and say, you know, this OT that we have just came out of a NICU rotation or something like that. And we want to make sure that we're not just going by discipline, that we're choosing by the best provider. So sometimes that does require a change, and we're trying to get our teams to think flexibly when they're recommending the service. For example, oftentimes our families, maybe we would be, I'll use speech and education as a good example, that either provider would be a good support for the family, but we have somebody who speaks Korean who's an educator, and we know that that might be more supportive for mom rather than having an interpreter, where we would then make the educator the primary provider, but she has a speech therapist on her team. So if she gets stuck about articulation or something specific, that she can bring that person in with her if needed, or she can just bring information back to her team and ask questions and have support. So when you have that scheduled teaming, there's no ambiguity about, is there going to be a time for somebody to support you? I want to answer your question, Corey, but I'm not sure what it would mean to become the default PSP. I'm guessing if you mean you're the only person on the plan. Is that what you meant? I'll wait for Corey to answer here in chat and make sure that I'm going the right direction with what she was asking.
Susan, while Corey's typing in, I'm wondering, I'm listening to you all talk about your teaming, and I'm wondering how the service coordinators play into this, because I'm thinking as a former service coordinator, what you're talking about, this needs to change. Sometimes you would change to a different provider if that was a better match. Do your service coordinators join the team meetings, or how are they kept in the loop?
I'm going to let Tracy answer that specifically because her team has a really great way that they function. But let me again, I'm always willing to say where we're not doing things the way we'd like to be doing them. Our team, often across our system, our team meetings the team meetings I'm talking about today are meant to be clinically supportive. However, sometimes that turns into a discussion about services, and if the service coordinator is not there, we realize that's not the best way to be providing that service. But because we have so many providers and oftentimes we don't know when it's going to evolve into that kind of discussion, the service coordinator may not be there, and we recognize that that's something we need to get better at doing, and we're trying to use technology and FaceTime and Skyping to make sure that we get all the players there. But oftentimes the focus of teaming, when we talk about teaming to support the primary service provider, is the teaming to make sure that that person has the clinical skills to be the main support to that family. But I'm going to let Tracy talk about what it actually looks like in her team meetings with the service coordinators being there.
So we do have service coordinators present at our formal teaming meetings. We do, like I said, our big group teaming meetings. In Fairfax County, we work in 4 different regions. And in our big group teaming meetings, we typically have at least a service coordinator from each region, geographical region, present at our meeting. And then we also do more focused regionalized meetings. Now, that being said, we try to notify service coordinators ahead of time if we're going to talk about a particular child, even if it is just clinical issues, because as Susan said, many times those clinical issues later turn into IFSP issues, and we want service coordinators to be part of that team. That being said, it is, as Susan said, not a perfect practice, and there are always kids that come up that weren't planned to be discussed, or we discuss one child at a teaming meeting and it leads to discussion of another similar child at a teaming meeting. But we really do value the participation of service coordinators at our teaming meetings for, one, their perspective, and also for their support as we move forward.
All right, thank you, Tracy. That really helps. Yeah, that's what I was thinking. The service coordinator is is the leader of that IFSP team, so sort of lead how those teams function together. So thank you. That's exactly what I was wondering. It looks like Corey answered that question. She said she was just worried as far as the default PSP. She was worried that somehow a developmental service provider might be a default PSP in some regions. And I know, yeah, you certainly said earlier we wouldn't want to see that kind of thing happen. That should be an individualized situation.
Yeah, I think that would be a perfect example, Dana, of perpetuating the myths. If that's happening, we certainly want to make sure that that's not the case, or otherwise your referral sources are going to see that this isn't a supportive model for what the kids and families need. I see WDC had a question there too that I'd like Tracy to be able to talk about how we handle that from a contact perspective and her as a managing a bunch of providers perspective.
Okay.
So as a clinical,
just want to make sure you see us a little. That comment's a little ways back. That our person there is asking, what happens when you want to switch to a primary service provider, a particular person, but that person has a full caseload? How do you manage that? So go ahead, Tracy.
So as a clinical supervisor, one of our biggest challenges but goals is also to manage our staff's caseloads to make sure that we're aware of those changes that are going to happen and what's going to happen next. So that is one of the biggest things we push with our staff as a whole, is communicating to us as their clinical supervisors when they anticipate a change. Because if they anticipate this is coming down the line, then we often hold those spots for that child that's coming internally. It's part of our contract requirement to cover internally the children that we see. So for example, if a child is getting occupational therapy and we anticipate adding speech therapy to that plan, our plan is to internally manage that. If we are not going to be able to manage that, we work really closely with the county to try to support that, but it is pretty rare situations that we do that. And we also try to remind our teams that it's not, once again, a service, but a person that's the right fit. And so talking through it all from all perspectives of what works. If for truly we don't have somebody that it would make sometimes a total change to a new IFSP team, obviously that's not ideal. And like I said, it really does not happen very often at all, and we really don't want it to happen at all. So I mean, that I think is what's really important, of having that clinical supervisor to maintain knowledge of the staff that's present and maintain how that staffing is managed as a whole and what's coming down the pipeline. And this is where that open communication is really important. And even my speech therapist on my team, for example, will always tell me, oh, I have 2 openings, but I have these 2 kids I've consulted with a PT on that are going to IFSP review. So keep that in mind, because those kids are probably coming my way.
Okay. Now there's a question in here about pushback. Stacy wrote that she's pushback from providers due to having a very small team for a whole county. I don't know, Tracy, if you have any advice for her in terms of, I guess I'm thinking, and Tracy can type in there, but if you have a team that, I've certainly worked in places where our team was 1 educator, 1 speech pathologist, 1 PT, we really had a very small team to pull from. So I don't know if you have any thoughts about that.
So I guess my question on this is directly what time they're talking about. For our formal teaming, we reimburse our staff for formal teaming meetings if it was an independent contractor or a full-time staff member. Teaming is a mandatory requirement for our staff members for the formal teaming meetings. If it's more of an in-person experience as someone being mentored because they don't have the skills in another area, I believe that is something that is our responsibility of professional development, as it would be in any other area. We reimburse our staff for that time, but it's not a reimbursable service from the state, because this is the same type of professional development you would be doing in any practice. If you had a new therapist, for example, who's new to the field or new to EI just in general, that level of clinical support that they would need would be the same as anybody in an outpatient practice or anybody else would get for professional development. If we're doing direct guidance for a family, then we add those services to the IFSP or have that person come be a member of the IFSP meeting. And once again, that covers some of those payment issues. I hope that's answering the question.
Yeah, thank you. Thank you, Tracy. I'm going to go ahead, and I think there's a couple other questions that have popped up that I think will get answered as we move along. So I'm going to move us to the next question. We've been talking a little bit about the IFSP, and I know I've seen this question pop up quite a bit. What does IFSP look like for a child who has a primary service provider? So how is having a primary service provider and having the team support reflected on the IFSP? Which parts actually show up? Can you guys give us an idea of how this works for you?
Yeah, we'll answer that real quickly, and hopefully that will help. First of all, we have any service that's the direct services right there, just like it would be on the services page. So using whatever the monthly frequency typically is for that primary provider. I think the question was, what we got after the last one was, do you put every member of the team on the IFSP? And the answer to that is no. We put the people who will be directly providing services to the family. So we had a question about, and Tracy just mentioned it again, mentoring. It's a word that often comes up in a question when we talk to people in other localities about how we use it, and I think Tracy did a beautiful job of describing it. We see mentoring as being when a provider needs support in growing their own skill. And in our agency, the vendor agencies take responsibility for that. So when they hire someone, Tracy has a good sense of the skills of her staff. So mentoring might be discipline the same. You might have a speech therapist mentoring another speech therapist. That is not part of the IFSP. That is either done indirectly in a team meeting, or the person may come out with the provider to provide support to the provider. So the support is, they might just be using some great observational skills like we talk about when we talk about coaching, just watching what's going on and coming back and providing. Or they might be actually providing some suggestions to the provider. And oftentimes we find with mentoring it's really just reassuring people that they feel comfortable in their own skills. So those services are not written on the IFSP. But we do use that annual 6-month frequency for that secondary provider who's providing support to the primary provider. So let me just give you a quick example that I think kind of helps clarify that. You might have a child who, let's say a newborn who has a lot of concerns, and physical therapy is the primary provider right now, but the child is NPO, not getting any oral feeding because they're not ready for a swallow study. They're not ready to address that yet. It's not the child's, the family's main priority, but we might have a goal on the plan because the parent has identified at some point they would like this child to be eating by mouth. So you might see something like 4 times every 6 months, in 6 months for speech therapy. That service would be triggered by the family and the primary provider saying, guess what, it's time for the swallow study, or they just passed the swallow study. Can you come out? Let's look together. And so you're working together with that primary provider. That's just one example. You might do it as a joint visit. You might do it as an overlap visit. And then again, someone mentioned this in chat, you can add an assessment if you really need to go back and have another service or a one-time visit from another provider that's part of the IFSP. So that kind of gives a quick overview about how our IFSPs actually look. That having been said, we do want to make sure that the family knows, even though it's not on their IFSP, that they know that they have a whole team. So we do ask all our providers to talk about their team and use their name when they go out. And so if mom asks a question and the primary provider says, you know what, I'm going to go back and ask Robin about that. You remember Robin, she's a speech therapist. I told you I was going to take a video and show it to her last time. So we want it to be real, not a team in theory, but a team in person.
I think one other thing.
If you see, Leah had a question. Do you get any pushback from families who've been told, maybe they come with a script from the doctor that they're going to get multiple therapies multiple times a week, so they've kind of walked in the door thinking one way, and then we're using an approach that looks different. How do you handle that? Or maybe Tracy, if you've come across that.
So I can tell you we get that all the time, all the time. And I think it's something that we really have to teach our families, and we have to teach our therapists and our service coordinators and everybody how to talk to families about why we do things the way we do, and how, as a PT, for example, I am not acting as a speech therapist when in that family, but I have the skills to help guide them to a point, and I have the support of a speech therapist behind me. And if their priorities and concerns change and what we're doing doesn't work, there are those other services that we may go to. I think as Susan was talking about mentoring as a perspective before, she brought up the idea of mentoring a speech therapist to speech therapist. But we also, a lot of times with those families will use the idea of a mentor to have a speech therapist basically being able to support a therapist that might not have enough knowledge of, for example, typical language development. So that speech therapist, that physical therapist says, I think I have some concerns, but I'm not sure that I'm right on that. But I would expect that physical therapist actually should have a little bit more knowledge of that. And sometimes, as Susan said before, sometimes those mentors are really just to make our therapists feel like they're doing what they're supposed to do for these families. But if a family really does push for those services, that's oftentimes we will bring out a one-time visit with a speech therapist, or a one-time visit with an OT or a developmental therapist, or whatever, depending on who the primary is, to basically reassure that family that their needs are being met. And in many cases, that's what we need for those families to see. And in some cases, it's not what all the family needs. And in some cases, These are families who also access private services in addition to our services. And in some cases, these are families who do need two providers. They need to hear it from a speech therapist, these exact strategies. They just don't buy it from a PT, and that's okay.
Yeah, I think that's a great point, and I think there's a comment here that talks about working with physicians to help them understand the approach. I think that's a great point, even backing up further and helping your referral sources understand. Yeah. I'm going to actually move us to the next question, which is actually one I think you guys have addressed quite well. How is the primary service provider supported by their team members? What does teaming look like? I know you talked about the mentoring. You talked about a little bit about the team meetings. I don't know if there's anything else you guys would like to add to give folks an idea of how the teaming works here?
Okay, one thing I do want to focus on in this teaming, and then I'm going to let Tracy talk a little bit. I think we have touched on most of this, is we do make sure that teaming is documented. Again, something we could get better at, but informal and formal teaming needs to be part of the child's record so that we show how much support the team is getting, the child is getting from an entire team of providers, and something we're not great at, but we do want to try to get better at. Oh, I saw Tracy in the hallway and I showed her a video of this child's gait because I had a question. You know, all of those kind of things we want to make sure is happening. I think one of the things I want to say is as we've moved towards this approach, kids are actually getting more support from multiple disciplines. I know that sounds like that's the backwards of what you're thinking, but if you're really trying to implement this the right way, like many of our providers know the names of all the kids. So they can say, because they've heard about that child in team, as soon as you say, oh, I'm going to talk about Camilla, the OT knows who you're talking about even though they've never seen that child. We do try to make very clear that you introduce new children, even if you're only the only provider in there, so your team is aware. Is there anything else you want to add about the teaming, Tracy?
No, I think there's two big factors to think about. We do what's called more informal teaming, meaning teaming that does not happen with the service coordinator present necessarily. That is like what Susan said, is you just run into someone in the hallway and you show them a video. We do a ton of video shares in general. This basically shows someone, hey, this is what's going on, what do you think? That gives a provider an opportunity to try out things. And it also gets the family who, Leah, I know you were asking about multiple services. It gives that family that sense that my child has been looked at by an OT and a PT and a speech therapist, as opposed to us just telling them that. But the families a lot of times will submit the videos to us directly as opposed to ones that we take. So that family feels like they can really get the support they need. But I think that's where the videos play a huge factor. And we use those both informally and formally because sometimes it's nice for people to see as a big group meeting videos of kids they're not even part of the team on, because everybody has a kid that looks like that other kid that they can learn from as we look at that. But I think that the other aspect is those joint visits are a great way that we team. And those joint visits are really important for carryover of a child who might have one service as their primary and another service as a secondary.
All right, thank you, Tracy. We actually have a question from another Tracy. She wanted to ask you how many face-to-face hours of service is delivered in a week? I don't know if you have an estimate for that, or if that's we could certainly follow up with Tracy later.
So I would say it's not 100%. I think it depends on someone's level of experience, someone's level of other support. We're sometime between 20 to 24 face-to-face hours of service in a week, if that helps.
Okay, yep, that sure does. All right, well, let's tackle our last big question on here, which is billing. I know I've certainly had people ask me, how does billing work? How do you document intervention using a PSB approach? Do you all have any advice? Or really, my question is it any different than how you document any other intervention? What do you think?
I guess that's the answer. It really isn't any different. If you're on the IFSP and you're providing the service, you write a note that's submitted for billing. If you're teaming, if you're either providing teaming or receiving teaming, we document it in the chart, but it's a non-billable service documentation. And we do make sure, we do have a training and documentation for all of our staff that makes sure they incorporate ongoing assessment across domains into their regular service delivery nodes. And that just allows us, that's not only a primary service provider approach, but that allows us to have the information we need to do the exit indicators, to make sure at every review that we are looking at the child as a whole. So I wouldn't say that there's that much difference. I think the question came from, I'm not sure if they mean billing insurance and Medicaid or the contract provider's billing Part C. So I would say every system's a little bit different, and Tracy and I are both available to talk offline about your individual system if you have questions around that.
All right, thank you. That's great. And we'll give you guys everybody's email addresses as our last slide, so if you want to follow up with Tracy and Susan about anything more specific to your system, you're welcome to do that afterwards. So we have about 10 minutes left in our web discussion, and we wanted to kind of wrap up with some strategies and suggestions you all can use if you want to consider start using this approach in your locality. So Susan and Tracy are going to walk through just a bunch of great ideas. If you have questions about those, feel free to chat about them, or we can answer questions, as we go along. So Tracy and Susan, you want to talk us through some of the things that have worked for you?
Sure. I think we wanted to add these last couple of slides to say, this is a process. You do not have to jump in and drown. There are a few things you can do moving you down the road to using this approach to better implement teaming practices, and just really to be focusing on your use of family-centered practices that are around using a primary service provider. So if you think, oh my gosh, my system doesn't have the geographic support for this, we don't have enough providers, I'm hoping some of these suggestions will be things that you could do that say, okay, I feel like we're moving towards this as a system. So one of the easiest things to do is just start where you are right now, today. I would say take a look at who are your providers in your area, and see if you have any natural teams that have already developed. When I've talked to other local systems who say, we don't contract with an agency, so we don't have the benefit of that. When I sat down and looked with them at some of their IFSPs, they had these natural teams that had already evolved, in all truth, mostly because of geography. So that the speech therapist who covers this part of their catchment area is working often with the OT, and they already talk to each other on the phone. They just don't realize that they're already doing a lot of this teaming. So that when you went back and started with these natural teams, you think, okay, well this isn't as daunting as I thought it was. These people already know each other. How can I formalize that a little bit better? Or how can I just pull together those IFSPs and take a look at that? So that's a great place to start if you don't want to think about changing your contracting right now, or you think you don't have enough providers in your area to be able to do that. Sort of along those same lines would be taking all of your current kids that get more than one provider and bringing those providers together to talk about, who do you think the primary service provider is? We did this at the very, very beginning. It was such a great way for us to talk about how you choose the primary service provider. It allowed the teams to really talk about their relationships with families. So if Tracy and I were both seeing two kids, let's say we had two kids we shared, just for the two of us to sit down and talk about those two kids, and it might land that I'm primary for one and she's primary for the other, and it has very little to do with the difference in the child. It might be my experience, it might be my relationship with that family, but that was such a great way for people to go, you know what, you know when you go to a team meeting and people will say things like, I don't know, Mom always says, well let me ask whoever the other provider is. Some of those things are already naturally happening in that the parent has developed a relationship with one provider more than the other. So starting there is a great way. Schedule your first team meeting. You can videotape it and take some time to critique it together. So go ahead and just, if you have those natural teams, just schedule one team meeting. Pick a few kids that you want to team together. I will say that one interesting exercise is to not team the kids that people share. So that sounds a little counterintuitive, but think about it from the primary service provider approach. What we find is that when people do team, they tend to team the kids that they share. But what about those kids where you are the only provider? I would argue that those are the kids we should be teaming more in our formal teaming, because those are the ones where you are out there by yourself. A lot of the informal teaming comes with people that we both 2 providers are out there seeing the child. So you want to make sure you're focusing on those kids that only see one provider, and that those providers and those families also realize they have a team behind them. You need to support this as a system. So figure out how you can facilitate some staff training. One of the things we did in the beginning was ask every provider to just come back and talk about one of the things they're passionate about in a meeting. It can be quick, it can be a handout, whatever your system can support. But if somebody really knows a lot about articulation, give them a chance to get up with their peers and share that information. If they went to a training, have them bring it back to everybody and just share some of the key highlights about that. So you want to make sure that you're developing the staff as a whole, and I know it may be that you've got individual people out there, but all of those people have to maintain their licenses, so they all need to be building their skills. And how do we share that wealth across the system? Let's see, I think I've covered the ones that are on, developing a script. That's just an exercise where people can talk about, what do we say to families? How do we describe to them about our team? How do we let them know what's happening, what a primary provider is going to look like? And I do want to say that you want to make sure, and I know Tracy really feels passionately about this too, that you can't really move forward in this unless you know what the clinical supports are for the providers who are providing the services. So that's real important. Let's jump forward to the next slide because we have a few more. Tracy, you want to talk about the flexibility of the IFSPs, because your teams are really out there making those changes when they need to be made.
Yeah, I really think the biggest key, and this is one thing we've pushed really hard to our staff, is that IFSP can change at any point. You don't have to wait till the 6-month review. You don't have to wait till the annual review. That you can think about moving it around. That sometimes maybe, you just need a one-time visit with a speech therapist because you can't figure out what's going on. That sometimes that PT frequency needs to decrease and something else needs to increase. And really thinking outside that box and why. I think if I look at an IFSP, I think it's the best way to sense how my providers understand what's going on. If their narrative, for example, is very descriptive and very discipline specific, then I also think that they're not fully getting the idea of this primary service provider model. Because if they're writing each section and it's very, well, in gross motor they're doing this, hopefully we're past a lot of that. But I really think that we think about our goals as not our motor goals or our language goals, that we think of them as all inclusive. I think all of that helps us make this work together.
That was really well said, Tracy. I know we have about 3 minutes left, and you guys had a couple of more strategies on here. You've mentioned some of them. You talked about discussing who the primary service provider already is. You talked about supporting teaming opportunities. I like the idea of conducting the peer reviews. I don't know, and having folks research if they have concerns, they can go do some research on them. I don't know if there's any others you wanted to cover here, or we can kind of get ourselves wrapped up for the day.
I think we could probably wrap up, and if people have questions, we'd be happy to entertain them. I will say that now I'm coming from a local system perspective. One of the key things is that as a system, you need to provide the team the time and the financial support for professionals to support and grow each other. You can't just jump into this and think it's going to be more efficient and more effective if you don't realize that you need to have a staff competent to be able to provide the services this way.
So I think that's an important place probably for system managers or program leaders to start, is to really talk with your team to figure out their comfort level, like how we looked at comfort earlier in this web discussion, thinking about how comfortable are people feeling with this approach and where do we need to build the capacity. I like what you said before, Susan, about you sort of don't have to jump into this and drown. It's a process getting your staff comfortable to a place where this works well. And it sounds like you guys in Fairfax Falls Church have really done a lot and put a lot in place collaboratively across the different agencies you work with to make this work.
But we still have a ways to go. We're not perfect.
Yeah, absolutely, and that's kind of how EI works, isn't that true? Well, I wanted to just throw up here on the screen the email addresses, particularly for Susan and Tracy, so folks have them if you'd like to get in touch with them. If if you don't get these down really quickly, and you're welcome to email me, and I can pass the information along. But I know they're happy to talk with you to support you. I see we do have one last question here. Stacy writes, I don't see this happening in our budget. We've not received any formal training, yet we're doing it. So yeah, finding a way to get that training is certainly a challenge, and budgeting is a real issue. Oh, I see Susan and Tracy said we'd be happy to talk with you more about that, which is great. So I encourage you guys listening to take advantage of the experience we've had on the webinar because it's exciting to know we have some folks in Virginia that are really trying this out. And based on comments, I think we have some other folks too, so reach out to your colleagues to find that support. Any last words, Susan and Tracy, before we wrap up?
I'm just going to add this in chat a little bit. I didn't get a chance to say that we know there are given challenges. And I want to make sure that we acknowledge that, because I think my idea with these last couple of slides was really talking about things you can do to just get people thinking this way without making a change that's unsupported by your budget or your availability of providers or your geography, that kind of thing. Because I do think the reason that primary service provider was put into the 7 key principles is because we know that a family can learn more through relationships. So if we're focusing on that piece of it being family-centered, there's a lot we can do just to help our providers develop relationships that don't bring confusion and conflict to the family.
Well, I think on that note, that's a powerful note to go out on. So thank you, Susan, and thank you so much to both of you, Susan and Tracy, for sticking with these 2 web discussions. I really appreciate it. I think we've got just kind of started a good conversation in our state. And for those of you that joined us out of state, I hope it's given you some food for thought too. We hope that you will share the web discussion if you have others in your state or your locality that would be interested. It will be archived on the Virginia Early Intervention Professional Development Center site probably within the next few days. And we hope you'll join us next month in April for our next web discussion. That registration information should be going up soon. So thank you, everyone, and I hope you have a wonderful rest of your day. Bye-bye.
Bye.
Bye.